All righty, let's go ahead and get started. So thank you all again for being here today for the Center for Pharmacy Practice Innovation Seminar, our first of the fall 2021 semester and our first kind of partially in person, at least since February of 2020. So that's exciting. As you can see, the Smith 545, I'm sure y'all joining us on Zoom, we've got a few people in here, so that's exciting. Thank you all for being here. I am going to hand it off to our speaker for today. This is Dr. Michael Elliott. He's the Senior Vice President and Chief Transformation Officer at Centra Health. And he's got a great presentation ready for us today. So take it away, Dr. Elliott.
Thank you, Madeline. First, I want to say thank you. Thanks for the opportunity to come speak at my alma mater. I graduated from pharmacy school at VCU back in 2002. Although I know everybody's looking at me right now and saying there's no way, there's absolutely no way that he graduated that long ago. But it is true. And anytime I get the opportunity to engage with my alma mater, I definitely try to do so. Before I go into a short introduction, I just want to share that there's one thing that I can assure you from today. And that is that it will be all up from here as you have your presentations throughout the rest of the year. I will start at the bottom. We'll set the bar very low and we will move on up from there. But no, seriously, I share that because it's interesting career-wise thus far. As I moved out of the world of pharmacy and into health administration, a lot of people said, hey, that's the pharmacy guy. As I moved further into health administration, most of my pharmacy colleagues said, hey, that's the health administration guy. So I fit somewhere in between. I definitely love healthcare, and I'm curious about this thing we call our American healthcare system. And that's really the perspective that I want to talk from today. Just a little bit of background on me. I am from Hampton Roads, Virginia. I was born in Norfolk, raised in Virginia Beach and Chesapeake some. And then went to Hampton University as they were beginning their pharmacy school. Decided to travel up to VCU, however, and have my start to my career at VCU School of Pharmacy. From there, I worked for Centra Health for a number of years as a clinical pharmacist at Centra Norfolk General Hospital. Ended up working for Optima Health with Centra as well in the insurance arm. And then also working in administration with really opportunities throughout the hospitals and then running into ambulatory sites. That led me to my current role at Centra Health. About 9 years ago, I moved out here to Centra Health, which is based out of Lynchburg, Virginia, where I've had the opportunity to serve as Vice President of Operations, Chief Operating Officer, Interim CEO, and now Senior Vice President and Chief Transformation Officer. And I won't go into detail what a Chief Transformation Officer does, but as we go through the presentation today, you will see that I've had the opportunity to hit really every part of our health system and make sure that it's performing in the most efficient and effective way. So with that being said, I'm going to jump in and let's have a good time this afternoon. First, a couple of housekeeping items, claiming CE credit, and I'll probably put this back up at the end, but you have your course code here as well, 22207-18313. And then just a little bit more information that this is 0.75 contact hours. So let me tell you a little bit about Centra Health. Centra Health is a small to mid-sized health system. We are, from a total revenue standpoint, $1.2 billion per year. And what you see on the right side of this slide here is really what we consider our footprint. So in the middle of the screen, you can see Lynchburg, and that's actually where I'm presenting from right now. We have 2 hospitals in Lynchburg, Lynchburg General Hospital, and also Virginia Baptist Hospital. Those 2 hospitals were separate about 35 years ago, and then they merged to form Centra Health as we know it today. We're about an hour south of Charlottesville, We're about an hour and a half from the North Carolina-Virginia border. And to our west, we bump up against Carilion Health System. And then out to our east, we almost, if you look at our secondary service area outside of Farmville, we almost bump up to the outskirts of Richmond as well, as far as our coverage area. So if you take all of this, we are about the size of the state of New Jersey as far as our coverage area. However, there's only about 500,000 people within that footprint. Some areas quite rural. Our health system has a little over 7,500 employees spread throughout our 9,000 square miles. We have 4 hospitals. We have 4 long-term care facilities. We have a small health plan called Piedmont Community Health Plan. And we have a PACE program and lots of other parts to our organization. So before we go any further and stop talking about my health system, I want to go ahead and jump right into a question. There's no need to do a Zoom poll or anything else like that for this, but I want you to get the answer to this question in your head and see if you're right. First question. Hopefully you've heard this over and over your careers and your training. Which country spends the highest amount of their gross domestic product on healthcare? Gross domestic product being the summation of all the goods and services that are sold and bought in the United States of America. Give you a second just to think through that. And if you chose the United States of America, you would be right. We have a slide here that shows all of the OECD countries. These are countries that formed and joined something called the Organization for Economic Cooperation and Development. Currently has 38 countries in it. So there obviously are more than 38 countries in the world, but this is a good comparison based on other industrialized countries. So if you see, this runs from 1980 to 2018. And what you can see is our amount of gross domestic product sitting at 2018, just under 17%, and no one really even close to that for us. So you've likely heard this over and over again. I wanted to give you an actual slide that shows this information in an impactful way. Next, which country spends the most per capita on healthcare? So per person. Is it Switzerland, Germany, United States of America, or France? So once again, if you chose United States of America, you would be correct. And I found this slide interesting because it breaks it down, not just per capita, but where do those dollars actually come from? In this slide here, you can see several countries, and you can also see in the blue, that's public spending. In the green, it's private spending. So that's privately coming from either your employer or your insurance company, and then out of pocket. What you'll notice here is from a public standpoint, we're somewhat on par with other countries. From an insurance standpoint and your employer, it's way out of whack. And then we're pretty high from an out-of-pocket expense as well, but definitely not as high as Switzerland. So we have the highest amount of our GDP. This turns into a per capita number as well, where we spend way more than any other country, even though we don't have the highest out-of-pocket, but all added up, we spend way more. Question number 3. Which country has the highest life expectancy out of the OECD countries? Is it Switzerland? Is it Germany? Is it the United States of America? Or is it France? Give you a second to think through that. Well, let's take a look here. Out of those countries, Switzerland. And this is data going through 2017. So we know things have changed here the last several years, but this data will be updated. So out of the industrialized countries, Switzerland has the highest life expectancy. Guess who has the lowest? That would be the United States of America. So you can see that ranges from 78.6 years to 83.6 years, a full 5 years of life expectancy difference between the United States and Switzerland. This is why I entitled our talk today that healthcare is complex, but we haven't seen anything yet. We have a lot to deal with. A couple of other factors that I want to share with you and that we're going to talk through in a bit here just soon. Suicide rates amongst the OECD countries. They're the highest in the United States of America. This data goes through 2018. And this, I implore to you, once this data is updated and takes into effect the impact of COVID, I think these numbers are going to be higher for all countries, including the United States of America. Chronic disease burden. So let me describe this one to you. This right here is anyone who's been told by a doctor that they have 2 or more chronic conditions. And this is a percentage. So 2 or more chronic conditions that you've been told by a physician that you have. This data comes from 2016 and 28% for the US, far greater than others. This probably does not surprise anyone either. The US has the highest rate of obesity amongst our industrialized nations as well, with the average being 21%, and for this data, us having 40%, defined as a BMI greater than 30. And one more item, just to talk about the complexity of what we are dealing with. This graph here shows what's going on from a population standpoint. So this light blue line here is population in millions of those 65 and older. You can see that we are quickly approaching a point where there will be more people over the age of 65 than there are under the age of 18. That has huge implications for our workforce in the future, for Medicare in the future, and the Medicare Trust Fund, and Social Security as well. Healthcare is complicated, but we haven't seen anything yet. Question number 4. What percentage of the overall factors that make up your health status are based on the clinical care that you receive? So once again, what percentage of the overall factors that make up your health are based on the clinical care that you or your patients receive? Is it 20%? Is it 40%? Is it 60%? Or is it 80%? Give you a moment just to think through that. Okay. The answer is right here in the middle of the screen. Clinical care represents 20% of our patients' overall health status. So let's walk through this. This is actually a model used by the Robert Wood Johnson Foundation. And it looks at health outcomes. Those health outcomes are broken down into 2 factors: length of life and quality of life. We all know the definition of being alive is not being in our ICUs being kept alive by machines. That's being alive, but that is not living. So length of life and quality of life are the health outcomes that we're looking for. Those health outcomes are made up of several health factors. Those health factors are broken down into health behaviors. So these are decisions that we make about what we put in our body and what we do with our bodies. They make up 30% of health factors. The clinical care that we're so greatly trained in giving makes up only 20% of someone's overall health status. Social and economic factors. By now, everyone has heard ad nauseum about the social determinants of health: education, employment, income, family and social support, and community safety. Then last but not least, the physical environment. Air and water quality, housing and transit, these things have an impact on our overall ability to live healthy lives. So here's what I wanted to do over the time that we have left. We know that our healthcare system is complex. We know that there are many factors that are causing us to have to change or transform the way that we give healthcare. As a matter of fact, I would argue with you that from a health perspective, what we have historically had happen in this country is that we have hospitals that joined forces and came together and merged and called themselves a healthcare system. They weren't really providing great healthcare, they were providing great hospital care. And the evolution over time is that those hospital systems said, you know what? We need to be able to control things a little bit better on the inpatient and outpatient side of things. So hospital systems went on the journey to become healthcare systems. They acquired physician offices, some acquired health plans and long-term care facilities and other items to try to better manage the care of patients across the continuum. So we're sitting at this place where most places across the country now are really healthcare systems. And then the evolution that's occurring as we look at our overall mission as healthcare providers and health systems is pushing organizations to move from just being healthcare organizations to actually health organizations, which means we're looking at the aspects of people's health that really don't match up directly with our training, which is giving clinical care. So as I have grown throughout my career, there are several things that I've learned, and they've taught me that as complex as healthcare currently is, the next 10, 20, 30 years is going to be even more complex. We need our best and our brightest to work on these issues so that we can provide the most excellent care and not just improve healthcare, but improve the health of our communities. So let me start with people. Is anybody dealing with COVID these days? I'll share with you locally what's happening here in the greater Lynchburg area. 2 months ago, we had 72 hours in which we had no COVID patients in any of our hospitals. We find ourselves today with 75 patients. If we look back 1 year, we're taking care of more COVID inpatients today after having a vaccine out for almost 9 months than we were taking care of this time last year with no vaccine. And all the models are showing that for the state of Virginia, we're likely not going to see our peak for another several weeks. And then it's going to be a slow burn down for us to decrease cases, hospitalizations, and also ICU admissions and deaths. So my first point here is COVID is a big deal. but it's not the only job to be done. It is not the only thing that we have been working on. And as a matter of fact, COVID has exacerbated some of the inequities that plague our communities. There's more work to be done. So under people as well, the right people are our most valuable asset, and the future is unsure. I don't know if this has affected the profession of pharmacy yet, but the early studies are showing that the pandemic, even though healthcare providers have been called heroes, the pandemic is actually scaring people away from going into healthcare professions. They see the long hours, they see the burnout. And so we have some work to do as healthcare in general, as leaders within healthcare, to make sure that people understand it's all right to be able to go into healthcare. Third, the nursing profession and therefore healthcare is in crisis. Let me give you an example of that. In my almost 20 years since being in pharmacy school and 15 plus being in general healthcare administration, I've seen some ups and downs for nursing. I've never seen anything quite like what we're going through right now. And I talk to other chief nurse executives, et cetera, who say they've been in the business for 30, 40 years, and they've never seen anything quite like this. The burnout is high. The need is high. The population demographics that I shared with you are increasing. And the pandemic has really bust a bubble from a nursing perspective. So what we're seeing as an example, if you talk with your nursing colleagues, ask them what it's like trying to get travelers right now. So there's a little bit of a death spiral going on. This death spiral, if someone is working in your intensive care unit right now, they have their usual pay, salary, benefits, etc. That person right now, today, can leave your organization, go to work for a traveling company, and what you were paying your employee, you will now be charged 4 times that to the traveling agency for that same individual. And health systems were getting so fed up with that, they were actually having their staff leave, go to the traveling company, and then come back and work in the same unit. So many health systems have put into place now that if you leave the organization, you can't come back as a traveler. Nursing is in crisis. And I implore you as leaders within pharmacy to figure out how to make sure we don't get there too. The slide here says points of view and not answers. I don't pretend to have all of the answers here, but I do have enough experience to point out the things that we need to be looking for the future. I say again, healthcare is complex, but we haven't seen anything yet. So solving for workforce resiliency will be key. I'll tell you, I know you all work, many of you in clinical settings. The resiliency that's been needed, especially this last year through COVID, has been nothing less than heroic. There are people who are dedicated, giving all they have, but everybody has a breaking point. And right now, when I talk with my nurses, usually the biggest thing, now that we're going through a resurgence, is their disappointment, because they know that what we're going through right now is largely preventable. The patients that we're seeing now in our intensive care units and in the hospital are younger and healthier than those who hit us last year. And the compassion fatigue is real. So let's work anything you can put into place for yourself and also your teams around resiliency is a good move in the long term and likely the short. Diversity, equity, and inclusion are business imperatives. The demographics of our nation are changing and changing quickly. I was going to put up some US Census slides, but I think everybody already knows what that is going to say. We're becoming more diverse all across the United States. People needing to feel like they can come to their workplace and be their whole selves is important. And we've all grown up in different places, neighborhoods with different experiences. And if we do not take an active role in trying to better understand what makes others tick and what their experiences are, we will find ourselves in a much more complicated place than where we are now. So a lot of people like to say diversity, equity, and inclusion are the right things to do. I agree. But they're not just the right thing to do. They're going to become a business imperative. Your competitor will have a competitive advantage over you if you do not make a welcoming place for all in your organization. That's your colleagues and your patients. And then last but not least under people, change management. Of all the skills that I learned in pharmacy school, and I can tell you right now, nobody wants me dosing their vancomycin. But of all the things I learned in pharmacy school, one of the most important came around leadership. How to be a good teammate, how to challenge the status quo, and then how to make sure you implement good change management techniques. Communication, transparency, follow through. Those things are hard, but they're essential. If not, you will lose your patients and you will lose your people. So change management is a critical skill. So let's move on to operations. This is where I cut my teeth in health administration. As a director and a vice president of operations, learning the ins and outs of this thing we call a health system and how to make those pieces work most efficiently together. If you are in an organization that has not started a high reliability journey, I want all sorts of bells, whistles, and alarms to go off. And I'll connect this to some other things a little bit later, but what is a high reliability organization? It has a couple of tenets to it. You have to be preoccupied with failure. Failure is not an option. We should have 0 hospital-acquired infections. We should have 0 wrong site surgeries. You have to be preoccupied with getting to 0 and preoccupied with any type of failure that can harm a patient. Secondly, you have to have a reluctance to simplify. Pharmacy school taught me a lot about not simplifying things. We go deep. That's why we're instrumental members of the healthcare team. But we can't usually find an easy answer to most of the hard questions that we're dealing with. We can't simplify it because when we do, we leave other patients in the way of harm. The third tenet is sensitivity to operations. You must know what's going on in your care environment. We do something at my health system called daily safety huddle, so that all of our leaders can have situational awareness of what's going on, not just in their department, but the departments around them and the departments that they lean on to help give great patient care. It's every day, starts in the morning, usually lasts about 15 to 30 minutes. And you go through those failure points, anything over the last 24 hours or the next 24 hours that might cause patient harm. The fourth of 5 tenets is a commitment to resilience. I don't know about you all, but this is hard work. It's 24/7, 365, and it is easy to get worn down. You have to commit to this work around the clock. There's this phenomenon that happens in many hospitals and health systems over the weekend. So Monday through Friday, 7 a.m. to 7 p.m., there's a lot of resources. After 7 p.m., some of those resources go. After 10 and 11 p.m., even more. Wouldn't it be nice if people only got sick between the hours of 7 a.m. and 7 p.m.? Wouldn't it be nice if people only needed specialists 12 hours a day? And then let's talk about the weekend. That's a whole different ballgame. If your hospital or health system is set up such that you don't have the necessary supports at night and weekends, watch out. Number one, you're likely not giving the best care possible right now. And as things get more complex, it will cause even more issues in the future. And fifth, deference to expertise. High reliability organizations defer to expertise. And who usually has the most expertise about the details of a job being done? It's those who are doing the job. So you have to find ways to engage your frontline staff to solve problems. So become a high reliability organization, or at least get on the journey to becoming one. You really never reach it. But if you're not, please take that away. So health systems and payers will be strongly incentivized to move to value risk transference, and it will be accelerated. This is value-based care. This is why the federal government is pushing as many people as possible into plans like Medicare Advantage. Medicare Advantage is where the government says, hey, healthcare provider, here's a bucket of money. If you can take care of people and have some left over, congratulations, you've made some profit. If you spend more than that, sorry for you, but you go into the negative. That is risk transference, and that will be accelerating across healthcare into the future. Reality is also most modern health systems are built for acute, episodic care and not chronic conditions and systems of care. Wherever you are engaged, step back and take a look at it. Is it easy to coordinate care around multiple chronic conditions in your environment? If not, the bells and whistles better go off, because that's where everything is moving, and that needs to be efficient. Interoperability is critical. If you work within a system where there are multiple IT systems and some of them don't talk, and if they do talk, they don't provide valuable information, another set of bells and whistles should go off there. And last, on operations, rationalize your offerings. We can't be everything to everybody. Do what you can do exceedingly well, and then find partners who can help you be excellent in the things that you can't do. This is our last slide. I want to walk through these other items, and then we'll get to some Q&A. From a community standpoint, remember this: health happens in the community, not our hospitals and clinics. That's where healthcare happens. Most of us got into healthcare to help people. We can help people through clinical care, but most of us want to go a little bit deeper too. If you are a pharmacist, I know for a fact, even in short careers, you had a situation where you've run into a patient, number one, that may have struggled to get or pay for the medications that were necessary for them. And then, even if they are able to get their medication, for some reason, they're still not showing progress in whatever disease state they have. And come to find out, it might be their living conditions or other matters that are preventing them from reaching their maximum health. I know that's happened to you, so we can't just be healthcare. We've got to be health providers. Last but not least, on the community, once again, 80% of the factors impacting our overall health are non-clinical. So let's do the clinical exceedingly well, but let's also impact the non. Accessibility. Number one, affordability affects access. And everybody, literally everyone, believes that healthcare is too expensive. Most people believe that you get paid too much, that I get paid too much. In any way that we can cut some costs out of our system, we need to do so. The polls show it. Regardless of how much we are trusted, everybody believes that our healthcare system is too expensive. We've shown some data that shows that it is. From an accessibility standpoint, telehealth is here to stay. With broadband and the infrastructure bills coming through as well, out to the most rural places in most places in the United States, they will have broadband access across the country. Telehealth is here to stay. It may range from a use perspective differently across the country, but that is going to continually climb as the years go on. And then last but not least, several trends. Here is the bottom line. If you got a good thing going in your company or your health system, do not rest on your laurels. Revenues are always declining. Reimbursement is always being cut, and expenses are going up. If you get a little run where you are getting paid a little bit more, that's great, enjoy it. But expenses are usually climbing sometimes twice as fast as any reimbursement. Smaller rural health systems are particularly vulnerable, which goes into the next point. Industry consolidation will continue. In parentheses, if the government allows it. The FTC is quite active these days in looking at mergers and acquisitions. But from a consolidation standpoint, health systems are trying to get bigger. And on the other side of the aisle, insurance companies are trying to get bigger. So I wanted to share with you just a couple of data points. For the companies, Anthem, Cigna, CVS, Humana, and United Health Group, if you look at their fastest growing service lines over the last 5 years, guess what ranks in the top 3 for all of them? Pharmacy. Pharmacy benefit management. Let me say that again. You look at their total revenue growth over the last 5 years, what's in the top 3 for all? It's them moving up the food chain and being more aggressive from a pharmacy benefits management standpoint. CVS Health, which is now not just CVS, but also Aetna. From a insurance perspective, their largest grossing area is pharmacy benefit management. Cigna is not too far behind that. And then Optum is huge. and is also not just an insurance company through United Health, but also has one of the largest groups of providers in the nation. Scale can help some things, but efficiency must win the day. That also rolls into the second to last point, which is payers are becoming providers, which I just described. And last but not least, private equity and venture capital organizations are just rolling the cash into healthcare for startups. So think about it like this. There is so much money exchanging hands in healthcare. If you just want to get a little piece of it, if you want to get a company started that just skims off a little bit off the top, you just want to make a profit of $10 million a year and you can find a niche to do so, why wouldn't you? But skimming those profits off the top, guess what they do to the rest of the safety nets that are trying to hold the system together? So just beware. If you haven't seen it yet, pay attention. Private equity organizations and venture capital are rolling millions and millions and millions of dollars into companies that have small niches that can skim some of the profit out of healthcare off the top. I'm not saying that that's bad, not saying that it's good. It just is what it is, and be on the lookout. So I hope, based on the experiences that I've had, I know this may be a little bit different than most of your CEs that go deep into clinical items around pharmacy, but hopefully today I've said a couple of things that will make you think more globally and think more long-term about where healthcare is and where it's going. Because once again, like the title says, healthcare is quite complex, but we haven't seen anything yet. Thanks a lot, and we'll go ahead and open it up for any questions.
Thank you so much, Dr. Elliott. We appreciate it. If anyone has any questions on Zoom, feel free to drop them in the chat or unmute and ask. And if anyone in here has questions, I have mics I can hand out to you.
Hi, this is Dave here. Excellent presentation, and I think this is a great kind of level setting as we kind of embark on the rest of this year. We've had a lot of conversations here at the school regarding, training the future pharmacy workforce, and and your presentation got me thinking, and I'd love to hear your thoughts on, what skills and abilities, beyond the clinical skills, obviously, should we really be focusing on as you kind of look ahead into the future needs of healthcare? What should we be kind of helping our students develop in outside of just the clinical knowledge? I'd love your thoughts on that.
Absolutely. Thanks, Dave. And it's a really good question. I touched on that just a little bit, but I can't emphasize enough around change management. So we might be able to come up with the right answers or what we think are the right answers, but our health systems are so complex that if we don't follow through on the execution, if we don't know how to engage with our partners all across healthcare, the best intentions that we have can actually end up in a bad place. So anything around change management, your emotional quotient, being able to engage with folks, control your own emotions as you engage. When things are complex, it kind of strips us down. It strips us down mentally, can even happen physically, even academically. We think that we see a clear line to how something should go and what the answer is, just to have it thwarted by a complex system that something is not easy to execute in. And I will tell you, hospitals have often been called the most complex organization in the history of man. the most complex organization in the history of man. And if you think about it, I think it's true. Think about all the social, economic factors that you deal with each and every day. Think about all the religious impacts and topics that you deal with every day. Think about the clinical nature of what we're dealing with every day and how fast our clinical knowledge is changing. Think about the number of subspecialties that we have within medicine and the ones that are growing. The amount of medical knowledge doubling, what I hear every several years now. And then at the center of all that, we've got humans. You and I, our patients families. And let's not even roll in the political nature of what we're dealing with as a country today. So change management and resiliency. I'll go back to those two things. Will take you much further, much, much further than many other skills. So Dave, I hope that was an adequate answer. Dr. DePiero?
Dr. Elliott, thank you for that excellent presentation. And I wanted to ask, in this country, we've had such fragmentation of healthcare systems for many years. And I'm wondering, from your perspective, do you see in the years ahead that there would be any type of consolidation in the types of systems, not from a corporate standpoint, but types of systems that are offered in this country? The word last year was Medicare for all. And I know it's much bigger than that, but do you see the fragmentation continuing or getting worse, or systems consolidating?
Yeah, so good question. And I see it from a couple of different angles. From a fragmentation standpoint, I think there will be small incremental improvements in the fragmentation of our systems. But I do not believe that we're going to have a panacea that will cause us to be more effective across the continuum of care. I think that's going to happen within unique organizations that have been able to find a unique path forward in the communities that they serve. And my experience there comes from all of the work around interoperability that's been going on for a number of years across the country. The fact that I think we are a long ways away from a universal health system. And so something sweeping like that, that doesn't even mean that the coordination is any better. That just means you have one payer. So some of our systems, as we work with, Medicare and Medicaid, are some of the least efficient systems. And so I would hate to spread some of that across our entire populace until those systems are a bit better.
Thank you.
You're welcome.
Yeah, go ahead.
Hi, this is Callie, and I have a question, Dr. Elliott. What are some resources you use to stay up to date with the trends that healthcare leaders need to stay on top of?
Yeah, so I'm an avid reader of journals, and trying to keep up with everything that's going on is really tough. So I have several items that send out daily messages about what's going on in healthcare. My email is littered with listservs, but I find most of the listservs do a good job of summarizing the hot topics and giving you just enough to be able to understand and piece everything you need to together. So there are some very good listservs. I find the American Hospital Association to be absolutely fantastic. Not just in high-level healthcare items, but really items that cross all healthcare professions as well. I like the American Hospital Association. If you really want something that's kind of juicy every day, there's something called Becker's Hospital Review. Becker's, Becker's, Becker's. And you can sign up and you will get some really, really high level hot topics. And what I find about what they report, yes, there's some headlines that will just grab your attention. But as you're looking to really improve the efficiency of your system, being able to advocate for things that will allow you to take better care of your patients, they do a good job of not just putting, clickbait up there, but things that are actually really insightful. So those are a couple.
Great.
Hey,
I'll have to
Michael.
look into those.
I have a question, Michael,
great.
and thanks for a great talk there. You're talking about process efficiencies and all of that. To what extent do you guys use data-driven strategies to improve some of those process efficiencies? And also, what kind of challenges do you have to using data-driven processes?
Yes, great question about being data-driven. If someone brings me an idea and no data, we don't even discuss it. It's just that simple. We must be data-driven in everything that we do. A lot of us have, gut instincts that we go off of, and that can be okay, especially once you've had significant experience understanding, the unseen. So what you can see that might impact a situation is one thing, but then understanding the unseen, the things that may impact you that most people are not aware of, that's okay. So we have to be data-driven because frankly, we just don't have the time not to be. What is the old saying for surgeons? Measure twice and cut once. So here's the other thing from being data-driven. Sometimes we have a lot of data, but we can't use it as useful information. So there is a such thing as analysis paralysis as well. And you have to kind of find that sweet spot where you may not have every data point that you need, but you got enough to be able to go off of. So I would just implore with you, if there are times you have to go off of gut instincts. In an emergency, when you are in charge and in command, you usually don't have time to get a whole lot of data. Get what you can, but you've got to make a decision. Most of us are not in that situation all the time. And so from a process perspective, if someone engages with you and has a good idea, but hasn't brought you any data, that's a good coaching moment to go back and find what data is available. And if the data is not readily available, then there are other conversations to be had, but always start with the data, because it will lead you in directions sometimes that is exactly opposite of your gut feeling. And we have to be mature enough to accept that and go in the direction of where the data is taking us.
Thank you, Dr. Elliott. Do we have any other questions as we're wrapping up? If you have another meeting to get to, feel free to hop off. But thank you, everyone, for being here, and Dr. Elliott again for this great presentation.
Well, thank you all. I love my alma mater. You all have continued to hold the flag of excellence extremely high under Dr. DePiero's leadership. Please continue to do so. Take care of yourselves and take care of those around you. Build up your resiliency. We've still got a heck of a way to go to move through COVID and then into the future as well. So thank you so much. I appreciate the opportunity. I've spent some time with you today, and go Rams.
Thank you.
Thank you.